Hello and welcome, everybody. We are live, and today we are talking to two amazing people, one of whom was actually, I'd say, the mastermind more than helped in developing the latest exercise training that is going live, launching at the end of this month. Now, this is, I hesitate to say it is my favorite training because that's tough. But I think it is maybe the most well-planned, most exciting training we have done to date, with the most practically applicable lectures that I've seen. And I mean, we make amazing courses, right? But this one is just, I think it's raised the bar a level up when it comes to practical implementation. And so I'm really excited to have Peter Cummings here, who is the mastermind of this practically implementationable training and exercise. So welcome, Peter. Thank you for being here. And then we have one of our wonderful lecturers. We have Dr. Rolandos Pavlou, all the way from Greece. And he speaks to the clinicians about how to amend your prescribing and medication in exercising and keto patients or clients. Welcome, Rolandos. Welcome.
Hello, Tamzyn.
Great. So I'm just going to give a little bit of a blurb about the training so that you know, hopefully you all know what it's about, but just in case you don't, tell you a little bit about the special that is only carrying on for the next week. So if you enroll now before the 30th of October, before the launch, you can get 20% off. So I want everyone to know that now is the time to enroll. And today, I think the focus is going to be on why. Why do we need to know about exercise? Why is it important? Why is an organization such as Nutrition Network that focuses on nutrition kind of going out on a limb and looking at exercise? Yes, we do cover nutrition related to exercise in this training, but why are we focusing so heavily on exercise? Why is this even important? And I think we really need to dive into this. And how does this pertain to clinicians, medical doctors such as Dr. Rolandos, dietitians such as myself? Why should we care? Why can't we just send our patients or clients to someone like Peter, who's an expert in exercise, or to the local gym where they can have personal trainers who tell them what to do? Or why should we care about this? And I really think, I'm just going to say a spoiler, we should care the same way we care about nutrition, for the same reasons. Nutrition is not a doctor's thing. Nutrition is for us dietitians and for the certified nutrition specialists. This is our camp. Nutrition's our camp. Why are doctors meddling in nutrition? It's a good question. The same reason we should all be meddling in exercise. Okay, so we're going to get into this in a bit more detail, and then we'll dive a little bit into the lecture topics that Peter and Dr. Rolandos speak to us about. So this exercise training, what sets it apart from, for example, our sports nutrition training that's already out there, is that it's focused on athletes. We do have a lecture on athletes, and this can apply to athletes, but it's not about athletes per se. It's about me. It's about you. It's about the normal person. How does the clinician, whatever kind of healthcare professional or allied healthcare professional that is, how do they implement the benefits of exercise or get the benefits of exercise into their common or garden regular Joe So patient in front of them? How do they assess? How do they prescribe? When do they refer? All of these things are really important because we were born to move. Because if we don't move, then we're all going to be like those people. I don't know who out there has watched the children's movie WALL-E, that robot, the rubbish removing robot, who all the humans leave Earth because it's so full of rubbish, and they're all for decades circling around the Earth in these spaceships. And how do they all look? They all look like big fat blobs who are on these, like, in these wheelchairs basically, that get automatically moved around the spaceship. They get fed. They don't even have to lift their hands. What are the implications of our sedentary behavior? And that's what this course is all about, and how to do something about it. All right, so we have Peter. I've told you already, Peter Cummings is amazing. He is spearheaded the curriculum, the planning, and everything. And he also does, I think, 4 lectures on this training. He is the Director of Health and Human Performance at Plan to Peak, where he specializes in preventative health and therapeutic carbohydrate reduction. He has over 30 years of experience, and he's recognized as an expert in human performance and has significantly contributed to the field by mentoring other preventative healthcare practitioners, and his work is focused on helping patients achieve optimal health through personalized wellness programs. Peter doesn't just deal with athletes. He deals with people who need the benefit of movement. He's also an accomplished endurance sports coach, so he can do that sports athlete stuff. And he has guided athletes to win numerous national state championships. But he's now, does a lot more coaching of people who need to get healthier and fight their metabolic disease, to be able to see their grandkids, to be able to tie up their own shoes, to be able to, do all the things that make us human, So Peter, it is such a privilege to have you here and talk to you about this training, your training, our training. Welcome again.
Thanks, Tamzyn.
And then Dr. Rolandos is also amazing. He's a Nutrition Network certified practitioner. He's a medical doctor. He's recognized for his contributions in the field of medicine and healthcare. He's known for his expertise in metabolic health, with a particular focus on the application of low-carb, high-fat diets and ketogenic nutrition in clinical practice. His work emphasizes the importance of personalized nutrition and lifestyle interventions in treating various metabolic disorders. He is very actively involved in research and education, and he frequently presents at conferences and contributes to academic discussions on the effectiveness of dietary strategies in managing chronic conditions such as obesity, diabetes, and cardiovascular disease. And his commitment to advancing knowledge in metabolic health and patient care has really earned him respect in the medical community and among patients seeking effective dietary solutions for their health challenges. He also engages in community outreach and raises awareness about nutritional therapy and holistic approaches towards health and dietary changes and lifestyle modification. So here we have an amazing medical doctor and we have an amazing, amazing health coach. Both are very capable in the research and academia fields, but they're also really, really knowledgeable when it comes to real life experience. So let's kick it off, shall we? I think I'm going to start talking to you, Peter, about the course, because I think a lot of people are still wondering why should they do it? And I know that you were saying, we need to train on exercise. So what was your inspiration behind creating this exercise course? And why do you think it's important for medical professionals who aren't necessarily exercise professionals?
Well, let's see. My vision of what healthcare could and should be is more of a preventative line of services rather than a reactionary. And it seems like healthcare has gotten so far away from that. I remember 30 some years ago when I was considering the field of healthcare, I was shocked as I was the eldest grandchild of my family. And I was watching my grandparents and bringing them to treatments and doctor's visits and realizing that no one was talking to them about how their nutritional habits that I was watching closely because I was part of the family and their exercise habits were just a part of the driving force of the chronic disease they were experiencing. And no one was talking to them about that. And so when I was deciding what to be when I grew up, I realized this is not what I wanted. And I was already exercising and working in a local gym and realizing that a lot of what I was learning about lifestyle, nutrition, exercise was applicable to this issue. And that started my journey. And I've been involved in health and human performance since then. But then, my relationship with the Nutrition Network got me out of my shell. So I practiced here in Buffalo, New York, and my athletes were all across the country. But my relationship with the Nutrition Network, in large part, was guided with my respect for Professor Noakes and his work in exercise. So when I heard he had finally stepped off the carb loading bandwagon, I had to learn more and found the Nutrition Network and then dove into all the courses. But then when the Nutrition Network provided that Nutrition Network medical practitioner course for the very first time, I became part of that. But it was since then, in my relationship with my classmates in that first group, and then being a tutor and mentor in previous groups, I realized that there were medical professionals that were gravitating towards the Nutrition Network because they realized that their education and training on nutrition and exercise, but mainly nutrition, had this huge gap in it. But then when we went through the courses, we were talking about exercise and how important it is, but superficially. And we were talking about sleep, and we were talking about stress, and superficially. But we really dove deep into the nutrition part, as the Nutrition Network should. But it started to, bring my vision, which was to bring exercise and nutrition into mainstream healthcare. And that's when it hit me after the last class that graduated. I reached out and said, the Nutrition Network is more than a nutrition network. It's more about an alternative healthcare education, and exercise deserves a spot at the table. And I know the importance of it, and I'm sure we're going to talk about it more and its impact on health and how it's different than low carb, but very similar in many ways. But that's what this course was about, is to bring, once we had our few meetings, it was about how to do that. And I almost wish I had more opportunities to talk about the why. But I brought in some other professionals for that, and Sina took care of a big portion of that. Rolandos took care of a big portion of that. And I got to focus on the boots on the ground, how you're actually going to do this in clinic, conveniently, safely, confidently. And that's how we came about this.
Thank you, Peter. That's such a great explanation. Rolandos, I would like to hear your thoughts on what Peter's just said. Do you think that do you think this kind of course is important for clinicians such as yourself, such as me? Why should we learn about exercise? Why is it important to our patients that we do? Why is it actually potentially an ethical imperative that we incorporate this knowledge into our clinical practice?
The truth is that it's quite new to me as well. But from preparing for my lecture, I came up with this idea that both are necessary. None of the two is sufficient. So we have to have both. We have to have nutrition and we have to have exercise. You cannot outrun a bad diet, but you can't also, on the other hand, be metabolically healthy being sedentary. There is no way this can be done. If you're sedentary, it's sure that something is going to be wrong with your metabolic health. And what we understand in the Nutrition Network is that exercise has an effect on the same fundamental mechanisms on which nutrition also can change lives, can bring full remission in mechanisms and subsequently clinical expressions in different diseases.
So Dr. Rolandos, why can't we just then focus on nutrition? Because exercise is quite unpleasant for some people. And, it takes a lot of time. Everyone has to eat anyway. So you may as well eat healthy stuff. So, I love playing the devil's advocate. So you're going to hear these kind of questions from me. Don't get too upset, Peter. But why can't we just focus on nutrition if they're addressing the same metabolic underpinnings? Nutrition and exercise help metabolic health, or they help mitochondrial function. They help muscle mass. They help. Why must we cardiovascular disease? I mean, tell me, why must we do both? Why can't we just choose the easier one?
Well, if Peter allows me to intervene, for example, what you referred to mitochondria, you may get healthier mitochondria and better function of the mitochondria with nutrition. But with exercise, you will multiply the number, and you will manage to have a much more effective factory energy production in the muscles. So most probably you will attenuate the effects of a hyperglycemia or in a metabolically unhealthy individual. So it's quite important to have the right muscle mass, which cannot be built alone with nutrition. You have to have some kind of exercise to multiply the mass, and you get more and more mitochondria better functioning.
Okay. So it sounds like you're saying that they complement each other. So
Yes.
The muscle mass one I can totally get. Okay. You can go onto a ketogenic diet, which saves lean body mass or saves your muscles better than any other diet that I know of. But it's certainly, no one's going to argue that it's going to build your muscles. Peter, I'd like you to weigh in on this. Why do you feel that we can't just eat right? Why must we exercise? Like, why do we even want big muscles?
Well, to oversimplify a very complex interplay, it's push and pull, right? So when we think about low carb diets and how they have this positive metabolic effect, we are fixing the input, right? What we keep stuffing in our mouth. Instead of eating a highly processed diet, we're eating one that's closer to what we were designed to eat. And in the process, we see a metabolic shift towards health, right? And what is that metabolic shift? Well, lower glucose toxicity levels, better fatty acid oxidation levels. We see less inflammation thanks to increases in ketone bodies. And at the cellular level, we do see happier, healthier mitochondria. We have improved metabolic flexibility, is what I just described, is the ability to burn fat rather than constantly store it. So that's great, but the exercise component fixes the pull side, right? So there's in our community, in fact, in the book behind on the shelf, chapter 1.2, the Unified Theory of Insulin Resistance and Chronic Disease, right? So we think about insulin in this hyperinsulinemic state that processed foods and sugary foods have put us in as a community, and fixing that, so decreasing the insulin load, improves our metabolic health. But exercise creates lean mass, which provides a greater reservoir for carbohydrates. So we have a limited reservoir of carbohydrate stores, and this is why we can become glucose toxic. We have a limited place to put these things. So if you keep eating them, when you've reached your maximum, your liver has to get involved and do something with them, and we see the triglycerides and the creation of the fatty acids. So we have that going on, but the exercise creates this bigger vat or bigger storage area because we have more muscle tissue. But it also decreases glucose load by introducing this concept of exercise stimulated glucose uptake. So when we normally think of, insulin is used to decrease our glucose load, exercise pulls the glucose in, so it translocates GLUT4 to the cell membrane, which is what insulin is supposed to do, but it's happening internally because of the contractions and demand on the mitochondria. So we're creating a better metabolic situation, and as Rolandos mentioned, you're going to get more biogenesis, mitochondrial biogenesis. So you're going to get more mitochondria, you're going to get bigger mitochondria, happier, healthier mitochondria. And while this takes place in a certain level by fixing the input, by fixing the pull, you really upregulate it. You turn the low carb exercise component into a super medication.
Wow. So I think I'm convinced. Can you tell us just a little bit about why we keep mentioning mitochondria? I don't know which of you wants to field this, but clearly mitochondria are important to metabolic health. For those who aren't sure why this is important, I don't know. Rolandos, do you want to tell us about why mitochondria are important to our health and longevity?
Well, first of all, it is the factory of the cell that produces energy, but it also is the antioxidant shield of the cell. So it's very, very central to the cellular health. Most metabolic pathways go through the mitochondria, and even cancer is considered to start within the mitochondria. And usually when we see modern disease from a point of view of mitochondria, we will see structural deformations of the mitochondria, which are linked to metabolic changes and disease. We see the cristae disappearing in many diseases, and we can see this in Alzheimer, we can see in cancer. So it is very, very central in health and disease.
And performance.
Yes, sorry, Peter?
And performance. Yeah.
And performance, yeah. Because, I mean, we don't want to, oversimplify too much, but mitochondria, the first thing you learn about them is that they are the energy producing factory of the cell. And exercise requires a lot of energy, right? So if your energy producing factory of the cell is not working properly, or if you don't have enough of them, which you need exercise to make more of them, then you're not going to be able to make enough energy, which is also why, I don't know if you feel this, but I definitely find when I stop exercising that my general energy levels go down. I'm just not as energetic. And I think a lot of people feel that way. It's similar to how when people start a keto diet, after they've adapted, they start feeling higher energy levels. That's one of the first things that happen. And similarly, people who start getting fit, they think, oh, well, they're expending energy. They're going to be more tired. And in a way, I suppose you're tired after a run or something, but it's a different kind of tiredness. And overall, you get more energy. Obviously, as Rolandos said, mitochondria are important for so many more things than just energy. They even control the start and the end of many neurotransmitters. In other words, the brain hormones that make us feel good or bad are often the synthesis and even the signaling, the receptors. It starts and ends in the mitochondria. So if you don't have healthy mitochondria, you're going to be pretty depressed, and which is another thing which is really interesting. Exercise has been shown, and I think, Rolandos, this was in your lecture, I think you said that it improves over 28%. So like, let's say almost a third of depression cases are going to improve.
That was even independent of nutrition. This study did not involve nutrition. On its own, exercise can have a major effect on mental disease. And I would like to point out another thing, that they also increase endorphins, and the exercise increases endorphins. And it might be interesting in the way of addiction. Maybe exercise can be utilized in our practice in dealing with drug addiction.
I love that. Rolandos, I love that. Do you know why I really love that? Because I've recently been speaking to a lot of people around me who are saying, this is in social circles, who don't know this kind of work, anything like that. And they say, so-and-so who has addiction to alcohol or drugs or whatever, they managed to stop their drugs, but they started drinking liters and liters of sugary fizzy drinks, or they started, so they switch over to this kind of sugar addiction. But if exercise can produce these feel-good chemicals, these endorphins, or improve mood, potentially, I don't know, this is going a little bit out of what we had planned to discuss, Peter, but do you think that exercise can be used as an adjunct treatment for addiction? And if so, how? Is it just the endorphins?
Absolutely. I mean, I think when you think about exercise, what are we really trying to drive here, right? It's fitness, right? And I think when you consider what is fitness, what are we talking about, right? Like I can talk about VO2 max and oxygen uptake and all that, but by definition, what fitness is resiliency, right? So what being fit means is you are resilient to physiologic, psychologic, environmental stressors, right? You think about the fitter you are, the more resilient you are to altitude, the more resilient you are to heat, the more resilient you are to cold. And when you think about fitness, you should be thinking about how much more resilient you are to psychological stressors, the stress of life. You sleep better. When you sleep better, you have better moods, you have less depression. And when you obviously are fit, we think of it as just a physical resiliency, right? These people can handle workload better than the unfit. But it all ties in. And I think this is why the data is so strong that cardiorespiratory fitness is the single best predictor of mortality and morbidity. Hasina, in her presentation, used a paper that it was brought to my attention that reduction in cardiorespiratory fitness is actually the earliest predictor of insulin resistance. And it makes sense when you think about it, right? As fitness goes down, we just talked about mitochondrial and energy production and how it's antioxidants based. And now all of a sudden you're losing that ability, right? So what starts to happen is all the things that we were talking about in reverse, right? You start becoming less insulin sensitive. You have smaller glucose reserves, right? Where are you going to put all this glucose if you keep eating it, right? So and we don't even use it. We're not using it because we're becoming more sedentary and we're losing fitness. So it makes perfect sense that as soon as you start to see someone's cardiorespiratory fitness decreasing, and in the course we show how it can be assessed in less than a minute with markers that are right in front of you in the EMR and just one question, and you're getting a very accurate prediction of where this person's fitness is, and that could completely change your clinical conversations. So I think it can be used in so many more instances, including addiction. And I do believe I pointed out to Rolandos because when he was doing his research, he'd always bring stuff like that up to me. And I do believe that in a lot of addiction programs, exercise is highly recommended and encouraged because of that.
Can I ask Peter, what do you think comes first? I mean, do you think that the insulin resistance you're describing as a product of lack of exercise, can it be the other way around, that an insulin resistant person has lower performance and therefore becomes more lazy, let's say?
Yeah, I think it's both. I don't know. This has been a question I've been asking personally and professionally for the longest time, looking at the data, looking at the thousands of people I've worked with. We talk about cardiorespiratory fitness. Okay, so one of the markers of cardiorespiratory fitness is this thing called VO2 max, right? But there's two ways to discuss VO2 max. One is relative, and that is relative to someone's kilograms, or absolute. So there's how much oxygen somebody can pull in 1 minute, absolutely. What is the milliliters of oxygen per minute? But then there's kilograms. And, I've always looked at our outcome data and try to figure out, when I see these massive improvements in VO2 max, I'm looking at relative. And if they lose weight, they automatically get fitter because they have less kilograms to divide the milliliters by. So that's why people feel so much better when they lose weight, is they're technically relatively fitter for the mass that they're having to carry around. But in our data, we see, especially in the high performers, people that really do well, is that it's both. Is they pull more oxygen, so their absolute oxygen uptake increases, and they get fitter because they've lost weight. So we see massive VO2 max improvements in that population, the overachievers, the people that, to me, prove that if you really want to change someone, that's what you need to do, is you need to not just reduce their kilograms so they're relatively fitter to the oxygen uptake that they have, but also improve their oxygen uptake, period. So in our overachievers, I see both. It's 50-50. So the people that really completely change, like if they ran into someone a year after they've achieved these goals, I see both. So I don't know, Rolandos. I think chicken or the egg, I guess it doesn't matter. I'd eat them both.
Yeah, probably a bi-directional relationship.
From a subjective point of view, many of my patients describe a mood to go out and run if they start becoming metabolically healthier. If they, I haven't coached up to now exercise, and I just encouraged walking and starting some exercise. I didn't know the science, so I just gave general guidelines, nothing specialized. But they describe themselves that as they get better and they resolve their insulin resistance, they feel that their feet won't sit down. They want to go out and exercise. Yeah. I don't know if it's subjective or there is something.
I think it's very real, and I think Tamzyn touched upon it. Right, you fix someone's nutrition, and they're less inflamed. Right, they oxidize fat better. Right, and let's face it, if you have had carbs and you had a good load of them, I think any one of us would have to admit that you get that crash after the insulin spikes. Right, so if you're walking around in that state all the time, I don't even care if you're in a calorie reduced state, but you're constantly eating small meals of carbs that are spiking your insulin, you're not going to have energy to move. You're in a storage mode. You're trying to figure out what to do with all this glucose. You're turning it into body fat. You're not burning body fat. And I think what they're experiencing is better metabolic function from the input side, which allows them to start moving. And then from an athlete perspective, as we've talked about and Prof has talked about, you get an anti-inflammatory response with more ketone bodies, more fatty acid oxidation, less reactive oxygen species. Our athletes recover better from not being in that state. So I would have to assume that the patients would recover better from being in low carb and moving, and then moving becomes easier. And instead of a vicious spiral in the wrong way, it's a vicious spiral in the right way for our health.
If I can add something, Ben Bigman describes it very well, that if insulin is low, lipolysis is obligatory. You have to break down. You cannot stop lipolysis, and you cannot stop burning fat. It's obligatory. Even if you don't have exercise to do, some kind of performance, you will burn it anyway. That's very interesting.
Absolutely. And I just want to add that anti-inflammatory effect of being in ketosis or a very low carbohydrate diet is going to make movement more, not just recovery better for the athlete, but if we're talking about the metabolically unhealthy person who's generally walking around in a state of chronic inflammation, and there's a lot of joint pain and all that kind of thing, you can also expect that to reduce, which makes exercising and moving easier and more pleasant. And then we didn't touch on, in this case, the mitochondria as well, which obviously if the mitochondria are getting healthier, then you're able to produce more energy, which is going to make you want to exercise more as well. So you're liberating
as well.
Yes, exactly. Uncoupled. So now this brings me to my next question, which is if you get metabolically healthier by eating a low carbohydrate diet, okay, now you're metabolically healthier, your mitochondria is better, your inflammation's better, you are able to access fuel that you weren't able to access before, so your exercise is easier, you feel like getting up and moving. Peter, is that sufficient? Is it sufficient to just feel like exercising and then moving more? Or is there a reason why one might suggest personalized exercise programs or intentional exercise programs to intentionally improve fitness, if that makes sense.
That's a core concept of the entire course, right? What is appropriate and what is the goal, right? So being able to assess a patient quickly in clinic, it has to be convenient, it has to be accurate, then tells you what would be the proper dose. For some people, getting up and moving more and going for a short walk a couple times a day is a serious training program. You give that same program to one of my athletes, they lose their fitness. So understanding that this is the important part of this, appropriate exercise prescription. Well, what makes it appropriate? Well, we want it to be safe and effective. Effective at doing what? Well, changing the metabolic state of the individual or improving the metabolic state of the individual. So, and I use in one of my lessons is that when you have someone with a very poor cardiorespiratory fitness through this assessment process, asking them to do a couple 15 or 20-minute walks a week is an appropriate load. Now, we think about the common prescription of, oh, you should walk 10,000 steps a day. Not for this person. That would be a toxic load. And Professor Rausch is going to give us a very real story about how after his life-changing accident, he was overloading himself. He was giving himself a toxic dose, which was really not helping his adaptation. He was not getting fitter. He was not getting healthier because he was making the mistake of toxic loading himself based off of the person he thought he was rather than the person he was truly at that point. And I think anyone can make this mistake if they forget that you have to assess yourself or you have to assess the person in front of you to prescribe correctly. And to a medical professional, that should be common sense, right? If I called Rolandos and said, hey, Rolandos, I got a patient here in Buffalo. He's a little overweight and deconditioned. Can you send over some meds? What meds should he take, right? Now, Rolandos is probably, you think I'm losing it, right, for even asking that, right? But if he was going to take me seriously, he would say, well, Peter, I need to evaluate the patient before I prescribe medications. What medications for what? Well, as an exercise professional, I ask the same thing. What exercise for what? And I think understanding that it has to be personalized to be appropriate. It has to meet the patient's fitness level and also their personal values and goals. And I think that's a really important part of this course too. Something that Deb Garrett brings into the conversation is how to be a good coach in clinic, how to let the patient tell you what exercise could bring to them, even though they don't understand it yet, right? Mm-hmm. You need to get them to tell you, yeah, I don't have any energy. You mentioned energy. I don't have any energy. I'm fatigued all the time. I find my activities of daily living difficult now. I can't do the things that I could do. And then as an educated provider, you can say, well, that has to do with your fitness. If your fitness was better, then those things would become easier again. And I can put a program together for you that can help you achieve that. Would that be of interest to you? That type of an approach is much better than just telling someone, hey, you need to exercise and eat better. That's why people come to me, because that's exactly what their medical provider told them.
So Peter, that brings me to the question about what can people actually, who take this course now, if someone takes the training, what can they expect to be able to do to help their patient better than they were able to do before the training? What are the tools that they're going to be able to learn if there's someone like me or someone like Rolandos who has not got a baseline training in exercise? What can we walk out of this training being able to do or offer our patients at the end of a consultation or at the end of a treatment series of consultations?
Well, I think the course goes into all the aspects. So we do cover the why quite deeply in the short time that we spend on it, to try and make sure that the provider leaves with an understanding of, I can't believe I'm not doing this for my patients. But then as you're suggesting, well, then how am I going to do that, right? And this is what we bring, is we teach practical, time-effective, safe ways of assessing the patient very quickly. Deb Garrett gets into how to have a conversation around exercise to try and increase the perceived value from the patient, because this is critical. I can't understate that enough. I could give you the perfect exercise program, Tamzyn, but if you don't want to do it, if you don't see value in doing it, it's just going to sit there, right? Like the same piece of paper I sent you is going to sit on your computer or on your desktop. Doesn't matter. You have to motivate the patient, and Deb's work on that, how to have a quick but effective conversation with your patients about the value that it's going to bring to them, to try and increase their motivation to do it, and then how to prescribe it based off of the assessments that you've done. So, you're going to be able to assess people's movement and assess people's cardiorespiratory fitness very quickly, and realize what they should be doing, what they shouldn't be doing, what's the right training volume. And if you do this routinely, you'll be able to track the trajectory. So if I gave you a VO2 max number for a patient, that's a one-off. It's kind of like a fasting blood glucose, right? But if you want to look at hemoglobin A1C, which is what's been going on over the last 90 days, you need two measurements, right? You need to know, is that VO2 max better than it was or worse? Because that changes the clinical conversation. And this is what the course will bring to the table for providers, is an understanding of how important it is, how to assess it, how to prescribe it, how to motivate people, how to track it, and how to know if what you're doing is helping the patient.
That's incredibly powerful, Peter. Thank you. And I think I think you've just encapsulated what makes this training so incredibly valuable, is you will be able to walk out of the training being able to do all of those things, to be able to improve the health of the person in front of you, which is so key. Now, Dr. Rolandos, you talk during the training about deprescription of medication and how to amend medication in the face of exercise, doing exercise. Can you tell us why medication prescriptions might change when you start to exercise? Let's say you're sedentary and then you start to exercise, and maybe you also start to adopt a low-carb diet. Why would these, like nutrition and exercise, alter medication prescriptions?
In the literature, you can find some case studies with titles saying that the ketogenic diet triggered ketoacidosis, for example. But if you look at the details, you will see that it was misdiagnosed or misdosaged medications. And it is not it's not like side effect. We should present it to the patient as an improvement, as a sign of progress, of recovery, because as metabolic health is starting to be restored, gradually you won't need the same medications you needed. It's something quite new to the medical world. We are doing something that is completely contrary to what mainstream medicine is doing, adding more and more medications for the patient without giving any hope of recovery. And now we present the case of the reverse procedure, where because of the improvement of metabolic health, with all the complications, all the repercussions on the whole body and many different systems, you can see hypertension, PCOS, and many other cardiovascular health becoming better and better. Therefore, medications start becoming redundant. You don't need to continue the same dosage, and we may end up discontinuing these medications. And we bring in the science of how to implement it safely, because we may have the opposite result that, for example, a hypertensive patient may end up with hypotension if we don't carefully monitor and adjust dosage.
So that's reversing. Really... Sorry, Peter.
Yeah, we're reversing a chronic disease pathology with this approach. And these medications aren't, people aren't walking around with high blood pressure because they have a lisinopril deficiency, right? So we have to realize that these medications are technically treating, they're siloed treatments, and they're not really addressing the root cause. So nutrition and exercise start to reverse this developing pathology or worsening pathology. And because of that, if you do actually begin to fix this, you start to heal this metabolic illness at its root, these medications can become toxic very quickly. And that's what the paper that I published in the American Journal of Preventive Medicine was about. Is we had a patient that was on dual action blood pressures and dual action glucose medications for his diabetes and hypertension for over 12 years. And within 6 weeks, his adaptation was so fast that we had to take him off all those medications because he was becoming hypotensive and hypoglycemic. So we did it in a safe way. I described that in the paper, but he responded. I don't know how many people see that type of response, or especially in mainstream medical practice. You just don't see that, right? You see, as Rolandos said, this changes your perspective from prescribing to deprescribing, and that's an entirely different perspective for most medical providers, is to see this. And I think that's why so many of the medical providers that have found the nutrition network and low carb are so excited again. They're rejuvenated, their practices are rejuvenated, because they're seeing things that they never saw with just the prescription avenue. Mm-hmm. And this is where I think they could be more pleasantly surprised if they implement exercise with their low carb and see the same type of miracle grow for health in their patient population.
Yeah, I think you've said it so well, Peter. I mean, what we're offering people with these kind of interventions is an improvement in health, whereas medications manage symptoms. They don't improve health. You just get more and more and more medications. And, people from, maybe more the Rolandos's era, maybe more the baby boomer, maybe my parents, they feel that medication, if you go to the doctor for a health condition, you better come away with medication, because otherwise they haven't treated you. Otherwise you've went there to hear that you must eat better and exercise more. I mean, so I think there's a huge change in mindset that needs to happen. And I like to think it is happening more and more and more rapidly. But even amongst us who have learned the value of dietary intervention, that actually it can be so powerful, it can therapeutic, right? Therapeutic carbohydrate restriction. It is when diet is not being used as a nutritional strategy, it's being used as a treatment modality to treat a disease. And similarly, it appears that exercise can be used for that as well. And I just want to touch on a lecture that I recently watched while getting everything ready for the launch of this training. Kyle Barrow speaks about movement. And he speaks about how so many people wake up these days with aches and pains. I'm definitely one of them. I've got this shoulder thing. I think it might be a rotator cuff injury. I'm not sure. And I'm not able to do my surfing anymore. I'm not able to do any of those things I love doing anymore. I can't even trim the trees properly anymore. And why? Why did it happen? Because I was deconditioned and then suddenly decided to do a whole lot of push-ups. And there is a perfect example of a toxic exercise load and going into movements that haven't been well considered. He speaks about how you test certain movements, and then if you can do those, then you should do these kind of exercises. If you can't do those, then you shouldn't do those kind of exercises. And I think that's also important, that actually movement can change not only your metabolic health, can help contribute towards the resolution or the remission of diabetes, can contribute towards optimal body weight, can contribute towards, the cessation of a whole lot of metabolic health conditions that kill us, but also can resolve the pain that so much of us walk around with on a day-to-day basis or wake up with. And I think that's really, really important too. So it's a quality of life question, and it's powerful. This is not just exercise a bit more, do some Jane Fonda tapes. This is therapeutic. This can change people's lives. So I think it's really, really important for every clinician to take this course and know how to, in just a few minutes, add this as one of their treatment modalities that they can offer, and an incredibly, incredibly powerful one. So Peter and Rolandos, I'm going to ask you both to end off with maybe a story. I know, Rolandos, you don't deal with much exercise interventions, but I'm sure after this course you will. I know you deal with deep prescription and things like that, and nutritional interventions, lifestyle interventions. But maybe you can each share a case study for me, or just like a kind of example. Peter, you already shared one of how someone came off his medications. Can you tell me, what can people expect to achieve if they use these kind of interventions? What kind of benefits have you seen in your respective practices with ideally exercise, but also nutritional interventions? Pick someone that you can think of and tell me how was their life improved, just so people can really imagine this, visualize what this means to a person. Peter, do you want to start?
Sure. I think that patient was a really good example. One part that I did not mention about that patient, he did understand exercise was important, and what he was doing was walking 20,000 steps a day. Now that's a little over 5 miles. So when we first met this patient, his cardiorespiratory fitness was pretty decent, but he was still carrying around, I think it was 40 pounds of extra adiposity, and it was the low carb approach that helped him to lose the weight. But his fitness went up a little bit because he started to do some resistance training, and as a diabetic, the resistance training has been shown to be quite effective, and again, creating a bigger sink for any glucose that does come into the body, but also to stimulate mitochondrial biogenesis at a level that maybe he wasn't doing with just walking. I think there's some excellent stories that I could provide, but I think the biggest change in fitness, when you actually change someone's fitness, whether it be relative or absolute or both, is the improvement in activities of daily living and quality of life, right? Because as you were describing, your swimming is important to you, or your surfing is important to you. It provides you joy, recreation, a time to unplug from the nutrition network work, right? But if you can't do it, boy, life becomes miserable, because you're reminded of that every time you think you want to surf. And so there's a twofer. Not only can't you surf, but you're reminded of it because your shoulder. So I think people need to, I have thousands of these stories, because this is what is most impactful to the patient, right? They love when their doctor tells them their HbA1c is normal, and maybe they came off medications. That's all great stuff. But to the individual, it's my quality of life and my activities of daily living. And this is where I think exercise, movement competency, improving your ability to move without pain, this is where it really shines, is you're talking about value to the individual, and they see it and feel it every single day.
Thank you, Peter. I think that's exactly right. It's about their day-to-day life. Exactly. Rolandos, would you like to share either a case study, or you can tell us what you would like our audience to take home from this discussion today?
Well, first of all, I don't have much of stories to share, success stories, apart from this feeling I described earlier of patients wanting to move, wanting to go out and exercise, and suddenly changing their lifestyle from sitting down all day and feeling exhausted and a chronic fatigue. And then they become very, very active, and they become athletes. I have some stories like that, but the biggest story was myself. When I started my keto journey 7 years ago, after 4 months, I decided I had so much energy that I wanted to do some test on me. So I walked from my farm in the mountains to the seaside, which was 5 kilometers away. I swam 5.5 kilometers in 2 hours. And then I climbed back the mountains to my farm. And it was, I left home at 9 o'clock in the morning without having any breakfast. And I went back home about 3, 4 in the afternoon, and I wasn't even feeling hungry. That was mind blowing for me. I couldn't believe it. The energy I could mobilize. Now, last point I wanted to make is that if we want this to be successful, both planning, exercise, and the prescription, we may need to team up with different fields of expertise, but the main person we have to team up with is the patient himself, because she carries such information and can monitor their health much better than anyone else. So we have to inspire the patient to get him on board, convinced that this is beneficial, and so he can keep a diary of everything, pain, meals, pressure, glucose, anything that happens. You can learn so much from your patient, and you have to also share all the information, all the knowledge you have, the data you have, and respect their decisions. Because if you, the prescription and exercise prescription are medical acts, and we have to have the fully informed consent of the patient, so that they know what we are doing. They have the alternatives, risks and benefits of each alternative, and they are on board on this. Not just the classical medical model we have of practitioners who are taking decisions without ever informing their patients.
Absolutely. I'm sorry. I just want to say I don't think you can ever overemphasize that point, because every single medical doctor that I come across outside of Nutrition Network and the circles that I work in don't require informed consent, don't give full medical disclosure of the potential risks and benefits of the treatments. They don't really respect the patient in the way you've been describing, Rolandos, and I think that's so important. And I think that's also takes us back to Debbie's lecture, where she describes the importance of buy-in from the patient, and how to get that, how to work with your patient to do that in order to have sustainable behavior change. Because without sustainable behavior change, you're not going to get any of these benefits. You can only get benefits if you do the thing and continue to do the thing. Peter, yes.
Yeah, I think another thing is, and Rolando started to bring it up a little bit, is the use of other people. Like we need to start collaborating with people in the nutrition network. We have coaches, we have medical practitioners that can be involved. We have exercise professionals, and understanding that we can't do it all. And that's where Coach Bronson Dance lessons come in, is how you identify these professionals that might be able to help you with your patients, maybe monitor them a little closer, give them feedback a little faster, prescribe them a little bit more detailed, because they need that type of service to be successful. And we brought that all in to this course. So how to identify the professionals you want in your network, and how to communicate with them, how to inform them what kind of communication you want back, and when you want it, that kind of thing. It's all included, along with the resources that we're working on now to finish up.
Exactly. Thank you, Peter. And I just want to say that from the comments, we really appreciate all the comments we've had through this discussion. I'm sorry if I haven't called you each out. I struggle with multitasking, but I did see that Michael Taylor and Ian Gorner have identified with everything we've been saying. You know, the whole you exercise more and you want to eat healthier, and then you eat healthier, you want to exercise more. And Ian said specifically that he really identified with your story, Dr. Rolandos, Pavlou. So about how, you know, you went on that walk and you had all that energy, and then you swam and you came back and it was all good, all on fasted state. He says he identifies with that. And I think anyone who eats this way does. Peter, you want to say something?
Shout out to Dr. John Cripps, who's
exactly
watching. One of my fellow classmates from back in, 2021 now? It's been a while. But shout out to him.
He's also now one of our tutors and one of our lecturers. He's amazing. So so shout out to everyone who's listened today. Thank you so much, and we really hope that you will join this training and add exercise and movement to your arsenal to improve the life of the people that you treat. Thank you, Peter. Thank you so much, Dr. Rolandos. It was great to have you both.
Thank you.
Thanks, Tamzyn.
Bye.
Thanks. See you, Rolandos.
See you.